think you're good to go.
Well, everybody, I would like to begin by welcoming those members of the public and the press who may be watching this live stream of this meeting via the County Council website. Members, you are now aware of the need to keep your video camera switched on for the duration of the meeting unless there are technical issues, and to keep your microphone muted, please, except when I invite you to speak. Please click the raise hand function if you wish to ask a question or make any comment at all. There's always a risk that we may run into any form of technical problems, and I will ask for your patience as if we do. Should this occur, I will declare an adjournment while the fault is addressed, and the public broadcast will be paused. If it is not possible to address the fault, the meeting may be abandoned until such time as it may be reconvened. Can I please remind members that all virtual meetings will be recorded, excuse me, and these recordings will be published on the Council's website. So members, I'll start please by calling your names to establish your presence. If you can unmute your microphone and confirm your presence, please. Councillor David Connor.
Present, Chairman.
Thank you. Councillor Lorna Dupre.
Present.
Councillor Linda Harford.
Present.
Councillor Anne Hay. Anne? Are you there? Okay, yeah, Anne's here. Thank you, Anne. Councillor Linda Jones.
Present.
Councillor Kevin Reynolds.
Present, Chairman.
Councillor Mandy Smith.
Present, Chairman.
Councillor Susan van der Ven.
I'm here.
Thank you. With video, Susan, nice to see you. East Cambridge District Councillor David Ambrose Smith.
Present, Chair.
Fenland District Councillor Sam Clark.
Present.
Huntingdon District Councillor Sally Smith.
Present.
South Cambridge District Councillor Jeff Harvey.
Present.
Cambridge City Councillor Nikki Massey. Nikki, you here?
Oh no, she hasn't arrived yet, Chair.
Okay, and myself, Councillor Peter Hudson. We go to item 1 on the agenda, please. We see apologies for absence. Can I ask Rhiannon to update us on any apologies, please?
Hi, yeah, we have Huntingdon District Councillor Sarah Wilson, who's unable to attend today, and Sally Smith will be taking her.
Thank you, got that. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? No, so thank you. So we'll go on to agenda item number 2, please. We're being asked to approve the minutes of the meeting that's held on the 11th of February as a correct record. Can I ask, please, if any member who does not agree with this to raise their hand now? And there are no hands raised, so thank you very much. On that basis, we'll approve the minutes as written, and they will be signed off when we can get back into council to sign them off. Thank you. Okay, so agenda item number 3, we've been asked to note the action log, which was emailed to all members of the committee on the 3rd of March and also published on the council meetings webpage. Can I ask, please, if any member who does not agree with this proposal to please use the raise hand function now? There are no hands raised, so thank you. No members have indicated they wish to speak, so we'll take the action log as noted, as required. Thank you. Agenda item number 4 are petitions and public questions. There have been no petitions and there are no public questions. So we go on to agenda item number 5, scrutiny. It's the Cambridge Cancer Research Hospital project and engagement update. Can I now welcome Sarah Vincent? There you are, Sarah. Hi. Who's Head of External Affairs. John Spicer, the Project Director. Len Jabell is the Macmillan Co-Production Lead, and Hugo Ford, the Oncologist and Clinical Lead. Can I ask you, please, to present your report, but keep your presentation fairly brief, please, because all members have read this report and they can't wait to talk to you about it. So if we can have a very brief introduction, please. Thank you.
Thank you, Chair. So if I take the report as read, You'll remember, thank you very much for having us back after so short an interval. You'll remember we recently presented the plans to you for a cancer research hospital on the Addenbrooke's campus. So this is really talking about the work that we're doing with patient involvement, and to ask for your endorsement of the approach which NHS England have suggested, which is that with this level of patient involvement and consultation, they feel that this would then not need to go out for broader public consultation. That's the specific question we're asking you to bear in mind as to whether you would endorse that approach as we go through the discussion. Thanks. So if I hand over to Lenya, is it? So who's going to?
No, it's me next. You
Sarah.
go. It's Sarah. Hello, everybody. So I'm going to just talk you through the diagram, which it was in your paper. So I'm going to just share my screen. Am I able to share my screen?
You should be able to. There's a bar at the bottom that says share screen.
Okay, let's try sharing. Right, is that working? Are you able to see that?
Yeah, that's all good.
Good. Okay, thank you. So very briefly, with input from the patients in the Addenbrooke's Cancer Patient Partnership Group, which Lenya coordinates, and she'll speak about in just a moment, we have been co-producing our model of patient involvement for the Cambridge Cancer Research Hospital. We're going to be setting up effectively 3 new modes of patient involvement. And how we do that is still under discussion with the patients to make that work as effectively as we can. But effectively, the new areas that we're going to be setting up are this Cambridge Cancer Network, the Patient Advisory Group, and the workstream patient representatives. So the Cambridge Cancer Network is going to be a bespoke virtual group of people. Anyone can sign up to join that, but we will be putting out invitations through groups who represent our stakeholders and our patients. And I've sort of put some of these along the bottom in yellow. People can sign up to join the Cancer Network, and then they will be kept up to speed with the developments. We'll be able to keep them informed. And when there are opportunities to do surveys, we'll put them out through the network. And when there are opportunities to become more embedded or do pieces of involvement or co-production with us, we'll seek to involve people from the Cancer Network. Then we are embedding 2 patient representatives, I think. We're sort of trying to see how it works within the work streams for Cambridge Cancer Research Hospital. So we've had 1 meeting of our joint delivery board where we had 2 patients involved, and we will be doing that with all the work streams from here onwards. I think almost all the work streams, and the patients who sit on those work streams will then be part of the patient advisory group, which will be an opportunity for them to share experiences and to say what's working, to say what's worrying them, where they're being listened to, where they're not being listened to, to share experiences. And then the patient advisory group can feed into the joint delivery board and raise any issues they've got or support in ways that we can that they think are necessary to get the patient voice across. So what we're working through at the moment is whether this scenario 1 here, whether the patient advisory group is a subcommittee of the current existing Addenbrooke's cancer patient pathway cancer patient partnership group, and that's what we think is going to be the preferred scenario, or whether it sort of is independent of the CPPG. So that's just something that we're working through with the patients to find out what they think would work best. I mean, the benefit of doing the scenario 1 is that the CPPG is already up and running. Any patients can join it, any patients past or present or carers can join it, and it works really well. It has good terms of reference, and it would make sense to operate under that umbrella, and the patients would like that model. So that's what we think we're going for. And that's really all I wanted to talk through at this point. So I'll stop sharing now. And then Lenya, I think, would you like to add anything to that?
Yes, thank you, Sarah. I would just like to add that the CPPG, which I facilitate, is very much used to working in co-production. And so therefore working at the patient advisory group level would be in its usual way of working, that it's actually developing services with staff at CUH. It's already doing that. So that's why it fits at working at that level. But that, and just also to say that we have about 50 members. So we're drawing from those 50 members and have already established, as Sarah said, helping to create this strategy on patient engagement to help create what the patient representative roles would be. But the other thing I really wanted to emphasize is that for all those roles, for those patients that are on the patient advisory group, they know and recognize that it's not about they are giving their views as a patient, that can come into it, but it's about ensuring the patient engagement and involvement. So if they go to a work stream meeting and they feel that actually, you know, are we consulting patients on this or engaging with patients to find out what they think, then they'll raise that flag to say we need to get a wider view. And that wider view would then be pulled from the Cambridge Cancer Network, which, as Sarah said, is something that we will look to build as big as possible, as diverse as possible, through all the channels that we know and beyond, so to speak. So it's the role of those patients in the advisory group and on the work streams is to ensure the wider engagement. That's all I want to add.
Thank you. Members, please. Linda Jones.
Thank you. And you've clearly put a lot of time and effort, and I know this is ongoing as well, into patient participation and elements of co-production. And obviously have encountered and managed to avoid some of the pitfalls. I'm very glad, for example, to hear that when you have patient representatives on a board or whatever, you have two, because it's it's really important that they can work together and feel that they're not overwhelmed by the process. The other issue that I think you clearly have been tackling from this group of 50 members is about representation and the role of patients in not just representing, but taking back and working with the wider group. I think there's quite a lot of research suggesting that what can happen is the professionalization of representatives. So they do inevitably gather kind of expertise, and the more that happens, the more they sort of float away somewhat from the breadth of the patient participation group. And I just wondered if you had thought of ways in which you could counter that. I mean, there's clearly a difficult balance to be struck, because patient representatives are giving up time, giving up energy, and so on. But there are issues as you go forward of this professionalization, which can mean that the gap between what the majority feel and what the representatives feel kind of gets wider rather than narrower. So I'd be interested in any comments on that. But thank you very much. It's a very interesting model.
Shall I come back on that, please?
I can come back a little bit, and maybe Lenya as well. I don't know if you have any thoughts, but I think the key to that, I mean, you're absolutely right, Councillor, that this professionalisation does happen, and indeed some of the patients who put themselves forward for this sort of thing are self-selected as being, as it were, semi-professionals to start with. So it is a bit of an issue. I think all I can say is I think the biggest defence of this is having the largest possible group to draw from, and we've been really quite successful. You know, it was a slow burn, but over the last 10 years, I suppose, we've really built, an increasingly large and diverse group in the patient partnership group, and I think we'd hope to replicate that in the proposed network as well. And I think that is the best defence. I think is having the largest and broadest group to draw from, and then I suppose one has to talk about, which we haven't really talked about yet, but I think perhaps what that means in terms of rotation or mingling and so on within the groups.
Can I just add to that we're kind of following the model that we have for the CPPG already, which is a real emphasis on flexible involvement. So there's lots of people out there that don't want to sit on a committee. I'm sorry to say, but they have a lot to share. And so with the CPPG, we have a committee, but then we have a wider membership, and they're merely there for reaching out to with a small survey or just a question. And that's sort of our approach with the network. Again, is that the more flexible you are in terms of the commitment people have to give, the wider you'll be able to cast that net. And it might be then that some of those people become more interested and want to get more involved at another level.
And just to add to what Hugo said about the rotation, we're developing the role descriptions for the embedded patient representatives. Again, co-producing them with the patients as we try this out. But one criteria for the role descriptions will be that they do rotate, probably a 6-month stint, and then with a possible option to extend it for another 6 months if it's working. But that will, I think, ensure also that we get a variety of different voices and strengths coming through.
Thank you.
Thank you.
Linda, are you happy with that?
Yes, I think
I
think it's a really good model. Yes, I do.
I think so too. Yeah, it's fantastic. Thank you, Linda. Susan, please.
Thank you very much, Chair. And thank you for the report, which has got lots of encouraging things in it, and especially the continuity in keeping this project going in a difficult year. So I had a couple of questions under the heading of project update and patient engagement. Of course, the future patients will not necessarily be local, given the national and regional importance of this project. So I wanted to ask you about issues outside the hospital, which have to do with access for that wider sort of constituency of patients. And these become very important in reality and day-to-day reality. And so I wondered about your involvement in those issues of access, physical access, transportation, and so on. And that was my first question. And then I wanted to ask you about your main worries about the project, if you would be kind enough to share that in a nutshell. And one must always ask about money. And of course, it is an important project, and one would like to assume that means it's home free, but this is a very uncertain time in terms of finance, the big picture. And so what bumps ahead do you foresee, if I may ask? Thank you.
Thank you, Susan. So we've got accessibility with transport, main worries, and funding, basically. So could somebody come back on those, please?
I can start, and then I think others may want to come in. So specifically, as regards access or equity of access in all its forms, and there are a number of ways in which you can look at that, both in terms of physical access to the building, but also actually what we're really talking about as part of the broader project is hopefully bringing earlier detection of cancer out into the community, and that therefore we're talking about getting into some of our own communities who are difficult to access and groups who are difficult to access. that is a very key driver of the work that we're doing, particularly in terms of prevention, early detection. Now, does it feed directly into the design and thinking around the physical hospital? Not very much, except in as much as physical access obviously is. Does it feed into the ethos and planning for the services? Absolutely, it's a primary concern. Obviously, by their nature, some of the communities are difficult to access and therefore difficult to represent, feeding into this conversation we're having about patient involvement. How do we get involvement from some of these groups? And that, I think, will be a challenge, obviously, for the cancer network. But I think it needs to be absolutely a priority that we get representation, if we can, from across the spectrum. I don't deny it will be difficult. Money wise, we sort of covered this at the last discussion that we had, but briefly, we think an allocation of 150 million as part of the HIP2 project program, and that does leave a financial gap which we need to cover through a combination of philanthropy and charitable input, where we are, and the input from Cambridge University as well, and industry, including AstraZeneca. So we are pretty confident that we will get over the line, but I can't tell you right now that we have secured promises for all the money, because we haven't, and John may want to add something on that. I can't remember if there was a third question. Sorry, Chair.
No.
Was that it?
Just those two.
Yeah, okay. John or Lenya, did you have anything to add to that?
No, thank you, Hugo. From my side, I think you've made a good summation of where we are. We are probably at that moment of saying we're not far away from being able to push the button to move to full business case. We're now just quickly closing down the last problems, the last areas, going back round our users, going back round our staff teams to say, have we done the right things? Is this still correct? Because obviously, we're at the beginning step. We're at the probably the later stages of the beginning of planning a hospital, if this makes any sense. And we're just making sure that we're doing all the right stuff in all the right way before we get to formally push go. And some of that push and go will tell us our exact financial gap, because that dictates the actual capital value of the hospital you're planning to build. So we need to finalize the full hospital designs, work through with planners to make sure that we've captured all the relevant costs before you move to your full business case. So we're closing those kind of areas down now. And obviously, one of the big things we have to do is make sure that our patient-centered design really is patient-centered. It really has all the right inputs from all of our patient groups, so that you've touched on things like accessibility, because this isn't just about a hospital. This is about a whole delivery of a clinical modality that involves not just a building, it involves what that building actually does and what that building actually means.
Members, are there any more questions? There's no hands raised, so thank you very much. So that's, I think it's just fantastic. This is so exciting, and the consultation with the patient groups is really encouraging, because it's all to do with patients. It's all about the patients. We have to use this fantastic new service. So thank you for coming. And also, one of the purposes for you to be here was to you're seeking to invite 2 counsellors to join the Cambridge Cancer Research Hospital project as liaison counsellors, I think, which is fantastic, and we say yes, 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 please. However, at the moment, I would suggest the best way forward with this, with the agreement of the members of the committee, is to wait until after the local elections, when we know who will be on the new health committee, because this is the last one in this municipal year, and then we put that on the forward agenda, if that's agreeable, to ask for 2 councillors to join as liaison councillors to the project. Does everybody agree with that? Linda? Yeah. Linda.
Sorry, I just noticed that one of the issues we're asked to approve or confirm is that formal consultation is not required. So I just sort of thought we'd kind of almost done it, but hadn't quite.
Yeah.
That's correct. It would be helpful to have a view on that point.
Yeah.
Linda, do you want to come back on that?
Well, I mean, I was comfortable with the model
Yes.
of patient participation, but I just thought that, I mean, if others are, I thought the committee ought to just approve it.
Yes, absolutely. I think it's all about the patients, and the more they ask patients, the more input patients have, the better it's going to be. So let's ask a doctor or a man who's closely related to a doctor. Jeff, please.
Yeah, so just touching back on the funding gap and the need for philanthropy and charitable giving, and I would thought when we keep reading about people who've made who've captured very large contracts during the COVID pandemic, and so I think it would be very fitting if some of those people were to dip into their pockets at this point. Whether that can happen, I don't know.
I think we all cheer with that, Jeff. Yeah, thank you. Anne, please.
Thank goodness my mute button is working this time. I believe that by the sound of it, they are talking to quite a number of patients and patient groups already. So I would say that it would suffice for the consultation.
Yes, thank you, Anne. Anybody else before I close this down? No. Okay, so the recommendation is we asked to note the report and confirm that formal consultation is not required in the development of the Cambridge Cancer Research Hospital, and we've learnt and we've agreed the process they're going through by involving all these patients and patient groups, which is I think the right way to go. So does anybody disagree with that recommendation? Please show now. No, thank you. And also Democratic Services, could you please make a note for forward agenda plan that we need to ask for 2 councillors to join the Cambridge Cancer Research Hospital project as liaison councillors, please. Yeah, we got that. Thank you. So thanks very much, Hugo, and everybody else. It's really great to see you, and we just can't wait for this to go forward. So thank you very much indeed. Thank you.
Thank you very much for having us.
Yeah, thank you very much. Bye-bye.
Thanks. Bye.
Bye. Thank you. Okay, members, thank you for that. Item 6 is the briefing paper in response to the childhood immunization. Sorry, my thing has gone wrong. Uptake during COVID-19. So it's Raj. Are you there, Raj? Give us a Raj. Can I ask, please, for a very, very brief introduction, because we've all read the paper. So just a brief introduction, please. Thank you.
Thank you, Chair. And this was a paper that was requested by Health Committee following a submission we did describing the Q1 data. And it just summarizes the system response to promoting childhood immunization. And there have been concerns both nationally and locally about what the impact has been of the pandemic on the immunization uptake. So this just summarizes where we are with it locally. So I think Health Committee is well aware of the importance of immunizations, and the PHE guidance is that we have to have 95% uptake, or as per the Public Health Outcomes Framework, 90%. So the tables are labeled in that way. So if, when we come to the tables, if we are over 95%, it's green, and over 90% is amber. It's important to say that we don't directly commission the childhood vaccinations program, which is commissioned by NHS England, but we do have a duty to promote the vaccinations and rightly so address any concerns that were raised because of fears that the pandemic may have adversely affected uptake, both in terms of increased parental anxiety and lack of services. Parental anxiety in terms of attending clinics and lack of services. So in section 3, the table just describes that Cambridgeshire has been achieving the targets in terms of the public health outcomes framework and achieving over 90% immunizations in all the vaccinations till the age of 5. And we are above national and regional average as well. The issue about school, so that's section 3. School age children, we get data from the community school aged immunization service, which is currently provided by CCS. And for some time, this was paused to help with when the schools closed. But there have been more community clinics set up, and boosters for the teenage vaccination program have been delivered, with prioritizing the older age children, and that's summarized in table 4. We've also put in some data about the seasonal flu vaccination program, which has gone well so far, and it's been better than last year, the flu uptake. And we know this year the flu season has been reasonably quiet, and it's said that it's probably because of the expanded immunization program and better uptake, in addition to all the other measures we've been doing for reducing the spread of COVID-19. So again, flu vaccination data suggests that we are doing as well as national or slightly higher. There's just a brief evidence review on how we could improve immunization uptake, but I won't go into details of that. And I'm happy to take questions.
Members, yeah, Lorna, please.
Thank you. Thank you very much indeed. I was interested in comparing this with the figures that we got back in September, which we didn't see in the report, so I had to do kind of manually. And I noted there that in most cases, what's going on in Cambridgeshire has been an improvement in the rates of vaccination coverage at pretty much all stages. And in most cases, we're doing better than the East of England average, with the exception of just one, I think. And the concern, though, is Peterborough, and we're not really here to scrutinise Peterborough, but we are adjacent to Peterborough, and that has to be, therefore, something that we need to take into account, where particularly at the 5-year coverage, the rates of immunisation appear to be universally falling across all those different vaccines, which has to be a concern. And I know it's not something that we can control, but I would be interested to know what was happening about that. Clearly also, although many of our vaccination rates are improving compared to the last time we saw these figures, nonetheless, there are some which are amber. And you said, Chair, that we weren't going to concern ourselves with the sort of ways of getting people to engage better with this, but I do think it's absolutely critical that we ask some searching questions about that, because that's the only way this is going to improve. And, you know, there are options such as taking the vaccine out to families rather than vice versa. But I do think we need to get to the bottom of what the constraints are. And obviously there's a huge, great constraint at the moment called COVID, which isn't encouraging for anything. But there are other constraints that I think we need to be thinking about and asking questions about to improve this situation and get the rates back up to where they need to be.
Thank you, Lorna. Raj, could you go back on that, please?
So totally get your point, Councillor. I think in terms of there were 2 questions there. I think in terms of what's happening in Peterborough, we do need to go back and look at what we can do in terms of promoting either through GP practices, through schools, through various routes that we have into the community. I think there's a lot of work going on in terms of improving uptake of the COVID vaccine as well in Peterborough. So we can work through the community groups to address any of the vaccine hesitancy. I'm not sure that there is any issue with access at the moment, but again, we haven't actually had a chance to look into exactly the reasons. But I think there was a study that was planned, which was paused because of COVID. I think Tia, our health protection practitioner, was, and Liz may know more about this, that there was to work with the CCG on improving uptake in Peterborough. One of our best start in life pilots, which is in Thistlemore practice, is focusing on increasing immunization uptake in that PCN area. So that's their main focus. So each of our pilot, I think last time I talked about best start in life, and we've got some place-based pilots going. So the one in Thistlemore, improving vaccination uptake, is a high priority for them, and or is that their main target? So there's a lot of work going on in Peterborough. In terms of the other question of taking the vaccination to the families and what resource that would need in terms of workforce expansion is something we'd have to look into.
Thank you, Raj. I think that covers that. Lorna, you okay?
Just wanted to come back very quickly. I don't think I was asking so much a specific question about that one aspect, that home visits, of trying to address the problem, more that I do feel we need to have a better picture of what the options are and how they are being put into place to improve this situation, because that's critical. And I didn't really get a picture that there was activity happening or how it was happening and how the effectiveness of that was being measured.
Thank you. Raj, have you got some very briefly to say on that?
So again, I think we only monitor what we get from the cover data, which is in the public domain. We are not privy to any of the that's NHS England who actually get that data on a monthly basis. So, and we don't have it broken down by GP practices or any of that, because again, that is CCG data, which we are not privy to. All we have is what's in the public domain, and the health protection steering group look at that.
Okay, Ross, thanks. That's perhaps something we look at in a bit more detail, perhaps in the near future. Linda, please. Linda Jones.
Thanks, and thank you, Raj. I think it's a really good paper. It's really interesting, and it demonstrates overall that actually the immunisation rates have held up pretty well. Better, sometimes better than others, but generally pretty well, particularly in the very small children, which obviously is really important. To some extent, it's a sort of historic paper in the sense that frustrated as we are that the data comes, kind of very slowly, and it's not actually completely authenticated or authorized or formalized until much later, and we sort of all moved on. But I was interested particularly in the section on school children, excuse me, because you had a higher degree of success than in previous years because of that big drive on flu vaccination.
Yeah.
And you mentioned that. You mentioned the lockdown problems, the lockdown pressures. But I think now you may have some indication, I know it can't be in the paper, of how the catch-up is going, because there is clearly a huge kind of area of catch-up work that's needed as schools are opening. And I think one of the things that worries me is that, as in Val's paper later, there are quite a lot of public health staff and indeed CCG and other commissioned areas where staff are being moved across to work on vaccination. And therefore some of the other work on other types of vaccination or other types of immunization, it is going to fall behind. So I just wondered where you were in relation to the catch-up plan for school opening, because opening's now happened.
Yeah, sorry, this paper was written before that. Again, as I said, Cambridgeshire Community Services, who deliver the the school vaccination program. They deliver our Healthy Child program as well. They've got a plan to catch up with the school immunization program. None of the children's staff have been redeployed into the COVID vaccination centers or the mass vaccination centers that, again, they run as well. So there isn't concern about whether the staff have been redeployed into other areas, because we monitor that quite closely with them. We did have discussions initially, but they have managed to find staff from other areas to do that.
Mm-hmm.
Okay, Ross, thank you.
Do you have oversight of the catch-up plans?
Not really, because they report that to NHS England. We actually have no contractual. They just gave it to us as a favor, but they don't have any. We don't have any contractual contractual levers to actually ask them for the data. And next year, it's moving to Hertz Community Trust, the school immunization. It's not even going to be CCS. We won't even get that data. It's all with
okay. It's not a very joined-up system, is it?
Yeah, but that's how it's been commissioned.
Thank you.
Okay, Ross, thank you. Linda Harford. Linda, please.
Thank you, Chairman. You'll be pleased to know that the previous two speakers have covered some of what I was going to ask. But I wonder if I could just ask a question about the BCG. Obviously, we don't offer that universally anymore, do we? But I wonder what the criteria are for determining children at risk of TB. I think I'm right in saying that the incidence of TB has increased in recent years. So what monitoring is undertaken of the need to reinstate universal BCG vaccination for school pupils?
So I think BCG is given at birth in terms of the children born to mothers whose original country of origin is high incidence of tuberculosis. So there is a list of countries where tuberculosis incidence is high, and if the mothers, it's all in the antenatal records, and if the mothers fall into those categories, just like the Hep B immunization for women who have Hep B, there is a whole recall system to make sure that those babies get the BCG vaccination either on the ward or outside. And it's, again, it's NHS England who keep monitoring they know how many eligible mothers are there. There's a list of countries, and those mothers' babies are called for BCG immunizations at birth or immediately after birth. I'm not sure that we give it in older children unless there would be such a high incidence. I'm not aware that there's a plan to start giving BCG in older children, but I've not read the Green Book recently, so I'm not lead with that.
Thank you, Raj. Yeah, that's something we can look at in the future too, perhaps. Anne, please.
Thank you. Within the report, it's acknowledged that certain groups don't take up the offer of vaccinations, such as ethnic minorities and areas of social deprivation. Do we know what plans are in place to try and educate people within these areas so that they feel more confident to come forward for vaccinations? And also, is there any data that shows whether vaccinations within these groups is improving or getting worse?
So that's a very important point. And the issue is that the ethnicity data is not very well captured on the immunization records. By deprivation, I think it's captured. Again, it is data held by the CCG. We don't get it by at that granular level. In terms of the practice level data is captured at the CCG, or the CCG have that through Inform. So I think in terms of work with those communities, I think there is a lot of work done by our community community leaders or with our community leaders, but I'm not fully cited on all of that. Again, as I said, it's mainly the CCG and NHS England.
Okay, Raj, thank you for that. Okay, members, there's no more hands. So if we can look at the recommendations, please. So we're asked to note and comment on the actions undertaken to date in responding to the ongoing pandemic on childhood immunisation uptake. This, I believe, we have done. So thank you, Raj, as always. Some good points put out there for perhaps future agenda items. So thank you very much indeed, Raj. Now then, Liz, do you want to do yours first, just in case anyway? Yeah, so we swap you over. So members, if we go to item 8, please, the Cambridgeshire County Council response to COVID-19, and the report was circulated to the committee on the 9th of February, I believe, and I accept it as a late report on the normal grounds, that is to allow the report to contain the most up-to-date information possible and to enable the committee to be briefed on the current situation in relation to the council's response to COVID-19 and for the services for which it is responsible. Liz, would you like to give a brief intro, please?
Thank you, Chair. Yes, and I'll just bring out some key points and messages that arise from this paper. And I think the first is that the picture in Cambridgeshire around our COVID-19 case rates is increasingly unequal across the county. So in Cambridge, East Cambridgeshire and South Cambridgeshire, we are seeing rates that have fallen considerably and are well below the national average. So these rates are not low, in that actually the very latest ones are probably just under 30 cases per 100,000. They've fallen even since the data I put in the paper. And back in the summer, that was a high rate. If you are 30 cases per 100,000, you were on the national watch list. So we still have not got really low rates of COVID, but certainly well below the national average and have fallen very satisfactorily. As you go north, and I will talk about Peterborough as well, certainly in the Fenland area and also the Peterborough area, we're seeing much more evidence of something that's now being recognised nationally as enduring transmission of COVID-19. And some of the features which have come out of national studies that are associated with enduring transmission are factors like employment, which means that people can't work from home, but also maybe low wage, agency, 0 hours or insecure employment, which places a very strong motivator for people that they need to continue to go out to work, whatever. There's also another factor is housing, where many adults live together or people live in multi-generational households with large families. And there's factors around transport and people travelling to work together. And what we see, particularly in the Peterborough and Fenland areas, and I always say we need to be extremely grateful to these workers and these businesses because they are keeping the country going through lockdown. We need to eat, we need things distributed. You know, this is absolutely critical, just as health and social care is. But what we're seeing is ongoing transmission and in some cases outbreaks, particularly for workers in agriculture, in food packaging, in distribution, in construction, in those sorts of areas of work, and in local authorities, which have a lot of that type of industry, and those other factors I described earlier. So that is something that we're seeing locally. We did have a visit from the Cabinet Office a couple of weeks ago, from the Cabinet Office COVID-19 team, to look specifically at Peterborough and Fenland and dig deep into some of the reasons and factors behind this, which was the visit went very well. It wasn't an inspection, it was generally working together, meeting with lots of community members. We met with some of the lead politicians, we met with employers. We really dug deep together into some of the reasons behind this, and it was very productive. But that means that actually Peterborough at the moment has rates which are the 6th highest nationally in terms of cases per 100,000 as a lower tier local authority. And Fenland is not in the top 20, but is still in the higher regions of national figures in terms of transmission. transmission. So that's something that I think this committee needs to keep an eye on, because if we think back to pre-COVID, we were looking really hard at health inequalities in the county, and we were focused on Finland and some of the enduring health inequalities that we were seeing in the area and what we were doing to address it. And I think we need to go back to some of that focus and really work hard. This committee needs to work hard going forward on addressing that and addressing some of the root causes.
Yeah.
Working with national governments. So I think that's a really important thing. Huntingdonshire also has above national average rates. I would say that for me, that is a little bit more about perhaps some specific circumstances and outbreaks. And I would expect to see Huntingdonshire coming down and getting closer to the national rates again. That would be my comment on the Huntingdonshire position. I don't think that's so much the enduring transmission. So that's probably a key point. Just moving on through, vaccination is clearly a good news story. We have now given more than 250,000 doses of vaccine. That was figures to the 28th of February in the Cambridge and Peterborough SDP area. And a question that came from the previous health committee or came from discussions with lead members and chairman, vice chairman, was about whether we're starting to see this in an impact on our hospital admissions. And I can say that, yes, we are just starting to see this. Our admissions are falling mainly because of lockdown, because lockdown is very effective, but we are seeing a faster fall in our over 80s and over 75 cohorts who were vaccinated first. So we are starting to see some impact of the vaccination programme on those issues. Apologies. So that's positive. At the same time, though, I think it's really important in terms of our messaging that we remember that we've only vaccinated part of our population, although quite a vulnerable part, and that most people have only had 1 dose, not 2 doses of the vaccine. We also just need to remember that it takes 2 to 3 weeks for a dose of vaccine to work. So people need to be aware. And I know we've publicised that strongly, that you're not safe straight after you've had the vaccine. And indeed, although vaccination is an enormously positive intervention, not everybody will be vaccinated. The vaccine won't work perfectly for 100% of people, they never do. And we have our groups with the highest rates of COVID, our working age population, many of them are not vaccinated. So it is absolutely essential that we continue to observe the appropriate measures for our stage in the national roadmap to easing restrictions. And at the moment, we're at lockdown, except that children can go to school. You can meet one person socially outdoors, and care home residents can choose one regular visitor. Otherwise, we're really still in lockdown. And it's so important that people stay careful, despite the vaccination programme starting to be successful. I'd then say briefly, lots of work going on community rapid testing. That's really important for the return to schools, that we are testing people regularly. We're still waiting to understand the exact impact that will have, but it should be positive if people test regularly. And I would also just flag a lot of effort going on at the moment into redrafting our local outbreak management plan. And the draft is due to be submitted to a regional level tomorrow to update our plans in the light of all the new developments. So I will stop there and wait for questions. Peter, I think you're on mute. Sorry, Councillor.
Sorry, I said thank you. And then I call for Susan.
Chair, I know that Liz, you have to go off to another meeting, so
3:30.
3:30. Okay, well, I'll just take the chance now to firstly thank you for this report and all of the reporting that you've provided us, and noting how effectively it's been received in our communities. And I know you have become someone who's referred to when people talk about, you know, what is the good advice that we should be following. And I know this is your last meeting, and it's the last meeting of this committee, and you'll suddenly disappear from our screen. So I really wanted to say an enormous thank you for all the years that you've shepherded this committee, and it's culminated in this extraordinary year. So just to wish you the best of luck and say a big thank you.
Oh, well, thank you, Councillor van den Ven. And I'd say two things. Firstly, it's an absolute pleasure working with this committee. It is an excellent committee, very well informed and asks excellent questions. And I would also say that although I'm the spokesperson, I have got an absolutely fantastic team. So you will continue to receive really good information and advice after I've gone. There may be a different spokesperson, but the team is excellent, and I know has been working very closely at local level with all the districts and cities across our area.
Thank you, Liz. We'll say all our thank yous a bit later. Could we stick to the paper, please, for the present time? Nikki.
Hi, my question won't be a surprise because Liz has heard me ask it before, but I think it's worth bringing it to this one too. Just the concern about a fourth wave. Now, we know the children have gone back to school. We also know that we are in lockdown. Lots of people don't seem to think that. We've seen the evidence. You just have to walk out onto any road, I think, and you can see groups of people meeting. Outside, yes, it is better than being inside, but they are still meeting. There can still be transmission, and we are seeing worrying signs in Italy of a fourth wave, and they're in lockdown. And so, just what the thought processes are for the future. And I know that we don't have a crystal ball, but we do have modelling.
Yes, thank you, Councillor Massey. I think this is very much the topic of local and national debate at the moment, and I know that the Chief Medical Officer, Chris Whitty, has spoken about this. In terms of the roadmap out of lockdown, I think that has been constructed on a good scientific basis, in that if you look at what it says, the relaxation of restrictions is quite limited. So that it really is at the moment about the harms to children of not being in school, and the benefits of getting children back into education and balancing that against any risks. So in terms of the structure of the plan and doing what it says on the tin, I think that's what it's about. And I agree, Councillor Massey, there is a challenge if people just, because people naturally sometimes do just interpret it as, well, this is the beginning of relaxation, we can relax a bit on everything. That's not how the plan's constructed, because we know that every change we make is likely to have an impact on the R rate and on the transmission rate. So, but we don't know exactly what that impact will be, because we've got a new variant, and we're not absolutely clear of the impact on behaviours like adults taking children to school, etc., etc. So that's why the Chief Medical Officer says we need to wait for 5 weeks before we do anything more. And admittedly, this one's slightly unusual with the school holidays on the 29th of March, but basically we need to wait for 5 weeks so that we can look at the data after each step and see what's happening, because it's not absolutely predictable. And there are the 4 tests, which we're all aware of, which are very much about looking at what is happening in reality after that relaxation. And of course, another unknown is absolutely how much impact the vaccination to date will have on reducing hospital admissions and mortality. That's something that really will be looked at very hard too. So I'm with the roadmap as it was written, which is quite a scientific document, with the relaxation of restrictions that will help to move us back towards this new normal, but which is taken very carefully and fully analysed at each stage. And if the data don't show that it's safe to go to the next step, then we shouldn't go to the next step. So that's certainly my take on the situation, Councillor Massey.
Thank you, Liz. Also, Nikki, if you have any issues just as that you want to bring up, you need to get hold of Councillor Bill Handley from South Cambs District Council, because he's the representative of all district stroke city councils on the local outbreak engagement board. And when the local outbreak engagement board meets, which we do on a regular basis, this is the very thing we are talking about in public. And as always, the way out of lockdown is purely down to people's behaviour, I have to say. Thank you. Where are we? Sally. Councillor Smith.
Thank you. I suppose it's not personal as such, but as a councillor, we're coming up to election times, and councillors are going to be out passing leaflets on to potential constituents. So what's the thought on that action as far as
can I come back on that, please? Because this isn't really a concern of the Director of Public Health. There is guidance out on when you can start campaigning and electioneering. It came out the other day, and it explains how and who and how many can knock on a person's door and stand well back. It's one person to knock on the door, you stand well back, and if the person who opens the door is happy to speak to you, you may speak, and you can now deliver leaflets. That's the official guidance. It goes into a bit deeper, but you all ought to have had that copy by now. Do you have something else for Liz, apart from that, Sally?
No, just that concern, thank you.
Okay, that's great. Thank you very much for the question. Linda, please, Linda Jones.
Sorry. Thank you. It's a really interesting paper, and I think it sends a really important message, two messages in a way. One is that what we've just been talking about, which is caution. And I mean, one of the things that is happening and people beginning to pick up are the research studies that are being done. And the most recent one, which King's has done, admittedly a small study, has been about people with cancer and the extent to which antibodies in people with cancer are much lower levels. And I think these sorts of issues just reinforce the point that Liz is making, which is that the notion that the vaccine will get us out of this in some dramatic way is absolutely not the case. And that we have to proceed very slowly, very carefully, and that if we don't do that, we have to take steps back, which would be pretty disastrous. So I think that that message of caution is tremendously important. And I do think that the evidence from different parts of the county, in particular from Fenland and so on, with the amount of agriculture and food processing, does suggest to us that it isn't about people's behaviour in a narrow sense of people doing silly things. It's actually about people's behaviour in a wider sense. And that was the second point I think that Liz made that was so important, because she linked essentially never-ending or ending the enduring transmission. She linked to the social determinants of health. She linked to people's jobs, she linked to people's contract type, she linked to people's housing, she linked to people's level of pay, she linked to transport issues. And it seems to me that for a health committee going forward, that is a really important concern, because what we've been trying to work on, particularly for the past year, is health in all policies. Now, if we're right, and I think there's a huge amount of evidence from Michael Marmot onward about the importance of bridging that health gap, if we're right about the need to end health inequalities and bridge the health gap, then it is partly the responsibility of the County Council to ensure that health is considered in every policy that the Council enunciates. And I think that is the message that Liz is giving to us. And it's, you know, it's a farewell message, yes, leave that all to Peter, but it is a really important message that we ignore at our peril. Because one of the things I think that COVID has indicated is that we are not quite all in this together, but that actually we have to move forward and make good some of the things that we haven't done in the past. So thank you very much for that report, Liz. It was really important.
Thank you, Linda. Liz, do you want to respond to that? I think Linda's just said you're wonderful and agrees with everything you've just said.
I think Linda expressed it extremely well.
I think so. So we'll move on. Thank you, Linda, as always. Anne, please.
Thank you, Chair. Within the report, it tells us from the period March 2020 to 26th of February 2021, there was 902 Cambridgeshire residents which had their death registered from causes related to COVID-19. And of those, in the last 4 weeks, 187 of those were in a 4-week period, which is over 20% of the total for nearly a year's figures. What concerns me is, and I understand that if you have tested positive for COVID within the previous 28 days, COVID automatically goes on to your death certificate. What concerns me is some of those deaths may well not have been from actual COVID. They in other words, they died with COVID, not of COVID. And what I would have liked to have seen is to put that figure into context, to have known the full number of deaths over that 4-week period as compared to previous years. I think that would have then give us a better idea of how COVID has, if it has, increased the deaths.
Okay, yeah, thank you, Liz.
Yes, Councillor Hay, we do have that information, and I will undertake to circulate it. We have charts which demonstrate what are called the excess deaths over a period, and I can say that we did see excess deaths over the second COVID wave over January and February. They have fallen again now. So in general, if you take the whole of Cambridgeshire, then we are back to the usual level. And you can also see how many of those deaths are related to COVID. And on the death certificate, it is the doctor's opinion that it is related to COVID when we look at registered deaths and death certificates. So we can see that. What you can also see, and I don't like talking about deaths in general, because for each death is a tragedy, and I know there's, for each person it is, they're thinking about a loved one who's died. But what you can see is that in the first wave in April and May, there were many more excess deaths which weren't registered as COVID. We had a higher rate of deaths, but they weren't all registered as COVID. What's happening now is that actually all the excess deaths are registered as COVID, and so even some more. So we are much better now at identifying COVID and recording things correctly.
Thank you. Thank you. Linda Jones, is that an old hand you're waving at me, or is it? Your hand's still there. There we are. Thanks very much. Okay, everybody, thank you. We're asked to note the progress to date in responding to the impact of the pandemic and note the public health response if you have done. Thank you. Liz, are you going now, or are you going to hang about till 3:30?
I'll stay until until 3:30.
Thank you. Before you go, could you tell me 5 minutes before you go, please? Thank you. Okay, so let's now go on to the next item, which is actually item number 7, isn't it? Because we've just done number 8, which is the Joint Commissioning Unit COVID-19 impact update. And it's Val, please. Val, could you give a very brief intro?
Yes, thank you, Chair. This paper is basically asking the Health Committee to consider and note the responses of our Commission Public Health Services to the pandemic. I think it has a couple of key themes. One about how services have adapted, and there's a certain key theme around sort of virtual adaptation as well. In summary, I think possibly in terms of the positives, virtual services has increased the number of contacts that clients with services have, but perhaps we haven't had as many clients going through the services. User views have been used throughout the whole process in shaping the service response. So a lot of work was undertaken with service users with regard to their views in how services could continue to be delivered, and they receive their support during this time. The things like postal prescriptions, things like telephone stop smoking services, they've all proved very successful and have had positive feedback. The other big thing is that is the partnership collaboration. I think probably the most obvious example of this is the response to when homeless people were taken off the streets and housed during the pandemic. And that really brought together our drug and alcohol services, along with mental health services, along with housing services and with sexual health services, and a lot of voluntary sector organisations to work together to ensure that the multiple needs that many of these people have were best addressed. And there's some very positive outcomes there in terms of the general health of this population during this period, which has been seen to improve. In terms of, we know there's positives, there's also negatives, of course. I think our primary care services that we commission from primary care they've been the most challenged in terms of delivery. Initially, obviously, a lot of access to primary care was extremely limited. and national NHS health checks were stopped. Access to long-acting reversible contraception was incredibly challenged in primary care as well. And in fact, that although that situation has changed in terms that national health checks, for example, can continue, we still find that because GP practices are still limit access to practices and also now very much involved in the vaccination programme, that still has remained rather slow in terms of public activity commissioned from general practice. Sexual health services, again, as the paper says, the Cambridgeshire Community Services staff who provide the service, some of them have been redeployed to support vaccination services. Our particular concerns around that, particularly again around long-acting reversible contraception, that is the service that seems to be most affected, though we do have an assurance that any of those high-risk women who do need that type of contraception, they are still prioritised and will still receive the service. And then probably our lifestyle services have been challenged as well, simply because a lot of them are run in groups. But secondly, access to community venues and GP practice venues is much more limited. In terms of long-term health outcomes, it's still very much an unknown. The National Child Measurement Programme actually just didn't happen this year. It tried to restart again in January, but then obviously schools closed again, and so that restart didn't happen. There is data emerging around obesity, which is not positive. In terms of drug and alcohol users, the picture is that clients have more complex needs, and there's been an increased use of alcohol as well. As yet, but other measures like teenage pregnancy, it's a little bit too early to say yet, but it's something we are monitoring very carefully. So I think in summary, I think the service has responded very well. There's been some really good positives and a demand that the different way of delivering services is sustained as we go into a different period. But I think there is some catch up that we'll need to do, certainly in certain areas around lifestyles as well. But some people really do enjoy the virtual lifestyle support. There's still a proportion of people, I think, across not just lifestyles, but all services still value the face-to-face contact. And as we go forward, how that is played out and how we can maintain our services to be COVID safe and meet that demand for some face-to-face support, I think that will be a challenge.
Thanks, Val. Yeah, some points there, isn't there? Linda, please, Linda Jones.
Thank you, and thank you for this, Val, because I know that it took a huge amount of effort, and you had to arrange far and wide to get this evidence together. It's a very meaty paper and a very thought-provoking one. I mean, in some ways, I think quite a worrying one. Clearly, as you say, there have been hidden benefits, and one of the interesting ones, which you've picked up really helpfully all through the paper, has been the extent to which there was a level of flexibility from big organisations like Change, Grow, Live, but also from small organisations like Diverse, who were switching to online, doing things in different ways, carrying over when contracts weren't ready, and generally making themselves available to fill the gaps. And that's very good. And as you say, going forward, there are clearly some elements of the online world in relation to public health and health provision, which can be made use of. I think the worrying thing is about the way that so many services have declined in terms of numbers of people using them, in terms of referrals. You mentioned particularly to LARC, and that may be an issue that in the future causes considerable distress for a lot of women. But there are other areas too. And one of the issues, it seems to me, is that, you know, to some extent, this has been, as in other areas, because people in public health have been working 24/7, as it were, on public health pandemic-related issues, as well as trying to keep services going. And I think the worry is that for public health, you're not out of the woods yet. Yet the expectation is that you need to get services up and running and vigorous again and back to their levels, and people need to be able to perform at those higher levels. And I mean, I wonder if you would comment on that, because it seems to me to be perhaps rather more of a challenge than you're suggesting, to get people reconnected with public health services, to get people reconnected with physical activity groups, to get people reconnected with management of drug and alcohol and sexual health problems and so on. And I mean, are there particular strategies, overriding strategies, looking back at this paper and at the report work that you've done, that you can see could be most helpful, most beneficial in moving public health forward?
I think the drug and alcohol service and the sexual health services, they tend to have, I think that they have very much have the same volumes going through there. Slightly less face-to-face, certainly in sexual health services, because of a lot of that, you know, the online contraception, the online testing. So I think that demand is there, and it is a very sort of clinical service. Both of them have a clinical dimension to them. I think probably, if anything, given I'd be more concerned about having so much more demand created by the changes in society that COVID has brought about. My main concern is that we get our lifestyle services re-engaging as quickly as possible. And I think a lot of that has started to happen. A lot of information is being sent out. And I think the Tier 1 service has already had some kind of, they do amazing sort of remote group sessions. But I think it will be very important, certainly I think across all age groups, to really have quite a concerted effort in saying how we're getting that message across. You know, we really have to start thinking about how we live our lives and all those things of the physical activity, which I think is going to be quite critical. I think I've read lots of reports about physical activities increased, but it's increased in those people that were probably increasing anyway. I'm more concerned about the people who perhaps find it more challenging for a number of reasons, and how we re-engage with those. I think that will be the key challenge for our services going forward. It's the one that concerns me the most out of all. I think the other services, I think there's a real appetite, for instance, like in the healthy schools, schools want support as they go forward, and a lot of work that's been going on in the previous months has been preparing for that. In terms of workplaces, again, one of the positive things of the COVID situation is that it's actually enabled a lot of relationships with workplaces, and it's been incredibly positive. But it's those community lifestyle services, and I think primary care has a big role to play in that. They always have done, in terms of referrals and that kind of endorsement of to people saying go and use those services. And a lot of referrals come from primary care to the lifestyle services. Not just the sort of weight management services, but more generally as well. So I think we have to take every opportunity as we go down the roadmap to say, what can we do now, and how can we best use those opportunities as we start to have more freedoms? Okay, how can those freedoms can be used effectively to engage people in those broader lifestyle activities?
Thank you, Val. There's lots of work to do for us in the future, or for us. Whomever's lucky enough to be put on this committee the next council. Thank you. Linda, the other Linda, please.
Thank you, Chairman. First of all, thank you so much for this report. It really is excellent, and there's an awful lot here to provoke further thought about an awful lot of things. But if you will just indulge me, I'd like please to hone in on something that I consider to be the scourge of our times, which is the increasing use of recreational drugs and the subsequent dependency on those drugs. So if we look at paragraph 2.1, the fifth bullet point says, reduce numbers using street-based drugs on top of prescribed medication, an increase in abstinence rates and a reduction in injecting rates. And my question is, please, on that, is there a connection between that and a statement earlier in the paragraph which says, in the initial lockdown period, reductions in detoxification medications ceased, and the focus has been on stabilisation of clients and managing risk. I'd really like to explore whether or not there is a connection between those two, because if I'm understanding those two statements correctly, and there is a link, I think there may be a very important lesson to be learned from it. So that's the first question, please. The second one is about homelessness. And I think that we've all acknowledged the impact that housing many of the previously homeless people who were in unsafe environments has contributed significantly to some of the positive outcomes. My concern is about how the situation of those housed temporarily in available facilities is going to be managed going forward. So how will alternative accommodation be found when those facilities return to normal operation? I'm assuming that at least some of them will. And I'm concerned about the impact that will have on any progress that those people have made. And lastly, my third question is, please, the additional funding secured by Cambridge City as one of the task force areas, is that only for Cambridge or for the whole of the county? Thank you very much.
Well, the last question is the easiest. It's just for Cambridge City and Peterborough, in fact. In terms of housing more generally, there's an awful lot of ongoing work, and there's numerous information coming down from the centre. And so I think that it hasn't ended at all. And I think I'd like more to talk about the local initiatives that's being taken forward through the Housing Board. And there's a very good collaboration across all the different housing authorities in looking to address this issue. And there has been some additional funding anyway outside of that funding. That funding is related to drug and alcohol, but there's other funding relating to housing as well. There's one that's already been secured and another one that's gone in as well that specifically addresses that issue of how are you going to sustain all these services being delivered in an integrated way to homeless people. There's also a lot of work around tenancies as well to get people into there's a term, secure tenancies, and people are assessed much earlier, and the whole system is better coordinated. But I still think there will still be some homeless people who perhaps, let's say, have a long-standing relationship with being homeless, and perhaps find it particularly challenging to be housed. And I think so how do you deal with those? How do you make sure those improvements in their health can be best sustained? And because I know the drug and alcohol service better, they've got really innovative ways of doing that, and they work very much with the housing outreach teams and so on. So I don't think it's gone away. In fact, it's pushed it up the agenda, and there's so much more local thinking about housing and how people can be brought into the whole kind of housing arena. So I don't think it's gone away, and I think there has been additional funding and there's additional housing being made available as well. It's just that just refers to the drug and alcohol funding, and that's just for Cambridge City. And I can't remember the name of the bid at the moment that went through that brought money to all of them, because there've been quite a lot of them. And the first one, can you go back to what you said then, because you referred to 0.21 or 0.22. Sorry, I completely missed it.
It was paragraph 2.1. The first quote was from the 5th bullet point, and then the second quote was from a bit earlier in the paragraph, where it talks about in the initial lockdown period. Do you want me to read?
Yes, if you read it, because I'm
okay. So earlier in the paragraph it says, in the initial lockdown period, reductions in detoxification medications ceased, and the focus has been on stabilisation of clients and managing risk. And My question
I'm
is,
with you now.
what is the connection between that and the 5th bullet point, which says reduce numbers using street-based drugs on top of prescribed medication?
Yeah, it's slightly different. When we first went into lockdown, many of the service users found it incredibly challenging. So if they want a structured program of gradual reduction, but that was people just couldn't cope with it.
Yes.
In effect, that reduction, they continued to have the treatment and they didn't reduce it. So it was more about reducing the risk, because they felt if you reduced it, it created risks in a sense, because people felt very destabilized, and really the treatment was sort of shaped around that destabilization.
Yeah.
And I think that the other issue is kind of somewhat different in a way. It's dealing with something different. And I think it's probably a positive statement in a sense that that you've had some increase in abstinence rates and reduction in injecting rates. So in effect, I don't know where, I think the discussions I've had with the team on this particular issue is that maybe people are on the streets less, there was that. And I don't think they fully understand why that we haven't seen that interrelationship between the use of street-based drugs and prescribed drugs. Access to prescribed drugs is perhaps been more difficult, but I don't think there's a clear understanding why, to be honest. The team don't seem to understand why, but it's been noted and recorded.
Thank you, Val. We need to move forward now. Linda, do you want to come back briefly, please?
Just very quickly, I just want to say that's exactly the point, the connection I've made. And I really do think it needs looking into, because it's that cessation of the reduction of, pushing them towards less prescribed medication that then doesn't force them out onto the streets to look for. I know that, I take the other points you've made about why they can't go out on the streets, but I still think there is a link between those two. And at least when they're on that prescribed medication, it's usually oral medication, which avoids some of the infections and things that they suffer from when they inject quite often adulterated material that they buy on the street. So for me, there is a definite link between them, and I think that it is worth pursuing. Thank you, Chairman.
The team think.
Thank you, Linda. Thank you, Val.
Sorry.
Thank you, Val. We'll take that forward to the future.
Sorry.
Thank you.
This is about harm reduction reproach, but there you go.
Yeah, there you go. Susan, please.
Thank you, Chair. I'll be quick.
Yes, please.
Yes, I wanted to echo many of the things that Linda Jones said earlier. In a way, it's an historic paper that we will look back on in years to come about the state of where we are. And I would hope that the paper could acknowledge the work of staff throughout this time in having to constantly adapt services as we go in and out of lockdowns. I know we've covered that in the past, but that's been something that's felt to me important to note, because we wouldn't have we wouldn't be able to function without our staff. I am glad that you highlighted the lifestyle services, because that locally, that feels, you can feel the impact of the absence there of many of the things we're used to seeing. And particularly in the third lockdown in winter, the lessening of physical activity, and that we notice. I wondered if the community groups that have grown up during the pandemic, and which are still active and very much connected to the district and county councils and plugged into public health, could be a conduit in months to come for some new thinking on regenerating some of the lifestyle services. I know that some of them have been thinking hard about both physical activity and social contact, which is, something we don't get in the same way through virtual connection. So I think that would be very welcome. And I think these community groups recognize that we have a long path ahead, even if some of the day-to-day requirements are changing in terms of community support. So perhaps that can be tapped into sooner rather than later as a sort of considering the terrain coming up.
Thank you, Susan.
Prior to this lockdown, we did have community health, socially distant community health walks going. So when it's appropriate again, it would be good to rejuvenate those as well. But you know, obviously within the COVID safe guidelines.
Thank you, Val. That's something we all look forward to. Linda, could you take your hand down, please? And finally, Jeff.
Yeah. Well, also echoing what Councillor Jones and Van der Ven said, my particular point is I'm rather worried that there never will be a day where we can say it's all over, because I mean, especially picking up on the enduring transmission. So that kind of implies that there never will be a day when we can say everything goes back to normal again in primary care. And I suspect that from some, depends what kind of a GP you are, but a lot of GPs will be saying, well, this is so much more efficient, this way of working. But of course, there are dangers there, because a good GP can tell so much about a patient just by the way they walk into the room and sort of their complexion and so forth. And I think we need to think ahead, you know, because I think there is a danger that which is borne out actually, but if you look, what I'm hearing, that the number of referrals to accidents emergency is quite patchy, because there's a discrepancy between the way in which individual practices either accept face-to-face appointments or don't. So there's a point there, but I think you could end up with almost a postcode lottery, just because some practices will just say, well, this is great, we'll carry on like that, whereas other practices will kind of want to go back to face-to-face. And I think the problem with virtual is that you may go to see your GP with what you think is your problem. Your GP, if it's good, will find that actually it's something different, and that will come from signs that you will pick up in face-to-face, which you couldn't in a virtual consultation. So I think it needs to be thought about as we come out.
Yeah, thanks, Jeff. And I can also say 99% of the people I talk to, they prefer to actually walk in and see their doctor as opposed to talk to him on the telephone or on a computer screen. Val, do you want to come back on that very briefly? There's not much you can say on that, I don't think.
No,
but,
I think there are risks and challenges going forward.
Yeah, Jeff says everything on there. I think that needs to be said. So thanks very much indeed, members. If we could please look at the recommendations we're asked to consider and discuss the impact of COVID-19 upon delivery of public health commission services, and to note the responses and adaptations of the service delivery, which we have done. Are you all happy to okay those recommendations? If you're not, please say now. No, okay, thank you. So we'll move on, please. Number 9, agenda plan, etc., etc., etc. We've all read the agenda plan as published. Rihanna, is there anything we need to add? Remembering we need to add the 2 councillors on the new health committee to go towards as liaison councillors to the cancer hospital project.
Yeah, I will add those on.
Thank you very much. Linda Jones, please.
Oh, thank you, Peter. Rising from the liaison meeting we had at Papworth.
Yes.
Did want to come and and talk to us.
Yes.
About their work, and also about the heart and lung research unit. So that was one issue. And the other one was about the STP, because quite a lot of what came up across the liaison groups and elsewhere has been about the impact that the pandemic has had, and we've just been talking about it actually, Jeff, you know, and others, on the way the health system does business, as it were, in terms of use of online, use of virtual, use of phone, etc., etc. We had that really interesting presentation some while ago from the STP. If you remember, I don't think any of us were terribly convinced by it. We had a lot of IT coming along telling us about how wonderful it would all be. It would be a really good thing to have them back, or some subset of them, actually saying, okay, how far has the agenda moved forward, and in what ways has it moved forward? What are the new sticking points, as it were?
Okay, Linda, so let's
infrastructure. Yeah.
Let's just put on the forward agenda plan, the calling in of Papworth Hospital for discussions on the subjects you mentioned, and also calling in the STP for an update, particularly on their IT. And this could be discussed and placed within the future forward agenda by the next chair and lead members meeting. Yeah, so that's good. Thank you. Nikki, please.
So previously in this meeting, we've discussed pavements and the link to health in the fact that people can trip, etc.
Yeah.
Is it, it's up to you, Chair, so it's more of a question for you, Chair. So after, we know that recently in January, sadly, a 5-month-old baby boy was killed in Waterbeach after a vehicle actually went onto the pavement where he was with his mother. That was Louis Thorold. Road safety really is valid, I think, when it comes, and it does link in with health. Is it worth on the forward agenda having road safety? Maybe Matt Stanton from Vision Zero or something. Obviously, you're more equipped.
Going on, going on to that. Hopefully, payments in the future with £20 million spent on them should be hopefully a bit better, and they are important, and they do add to health. You're right. Whether we get Matt Stanton in, I suggest we leave that to the next chair to decide. I would suggest, if I was the next chair, I would suggest a briefing note from the Highways Committee, perhaps, and some perhaps work between the Health and Highways Committee on this. But that will have to be decided by the next chair. But that's how I would play it, Nikki. Thank you, Susan.
Thank you, Chair. Yeah, I thought in terms of the next committee and whether we were going to leave a note for them about subjects we think they ought to be tackling, I thought we had, I think personally we should be leaving a few notes about, what we're concerned about with based on quite a few years of work that we've all done together. I think it'd be a missed opportunity not to do that, but I certainly haven't come prepared to this committee in that way because I understood that was not the protocol. If it is the protocol, then perhaps that's something we could arrange through lead members.
I'll discuss that with Liz and some lead members, and we'll have a look. Yeah, okay. Linda, your hand's still up. Is that an old hand?
No, it's actually a new
hand.
New hand, because what I realised was that the Health in All Policies agenda that Liz had kicked off, there's a senior public health specialist working on that, doing a gap analysis and so on. We put funding in from reserves to get that work done. We need at some point that to come back to committee.
Yes, absolutely.
Put that on. What the time frame was.
Yeah, that needs to go on the forward agenda plan, and I would suggest it's looked at fairly quickly in the next municipal year. Absolutely. And Kate, hello, Kate. Nice to see you.
Hello, everybody. Just picking up on kind of all the comments that everyone's been making about the forward agenda plan.
Yeah.
We actually do have a Leeds meeting with Health Committee next week, and I've put on that agenda a long discussion of actually the forward agenda plan going forward, and that could be almost your handover so it is on the agenda to discuss on Monday.
Thank you. Well, we'll all look forward to getting that right. Thank you. Is there anybody else, please? Okay, thank you. There's nothing to add, so we'll call that done. Kate, your hand's still up. Kate, your hand's up. Okay, so.
Sorry.
Thank you. So that's it. And this is the very, very last meeting we'll all be together. And I'd just like to say a really, really big, massive thank you to all of you who's made it such a pleasure to work with these last 8 or so years. Not all of you have been on the health committee all that time, but some of you have. I think we've done really, really great things, particularly our campaigns on smoking and all that sort of thing. And that's all down to your hard work and your dedication and your insistence that we look at things and we actually achieve things. So I should miss you all enormously, every single one of you. So thank you very much indeed. And just before we do go and dry our eyes, I'd just like to pay particular tribute to our public health team, who worked magnificently before COVID and absolutely were even more magnificent, I don't know if that's a word, but it should be, during COVID. And as a team, and when I used to walk down the corridor, walk to the public health offices and chat and discuss things with people, every single one of them were dedicated public health professionals who only wanted to work hard on our behalf to make life as better and longer for our residents. So a big, big, big thank you to them. They're absolutely brilliant. And finally, and certainly not least, is a big tribute to our Director of Public Health, Liz. She's retiring. How lucky is that, eh? But she hasn't gone unnoticed. There's nothing better than having somebody to work with, and they're as knowledgeable, who listens, who makes sure you get things right, and who isn't afraid to say you can't do that. I really, really, really appreciated it, Liz. It's been a real treasure working with you and your team. And Cambridgeshire will be at a loss without you, but I'm sure the next Director of Public Health will try and fit in your big shoes, and we just hope they manage it eventually. So a big thank you, Liz, and thank you for all your team, and a thank you to everyone on the committee. So that's it, over and out. Best of luck to you all. Stay healthy. Thank you.
May I speak, Peter? May I speak, Peter?